Here we are on the couch with John Dunn. John, you're a surgeon in Auckland, and today you've been talking about what?
Well, we had a really good session this morning on bowel cancer, a plenary session, and I certainly have my own opinions on that, but everything from causes to screening to primary surgery to management of metastases.
So screening's topical at the moment. So were you involved with the Waitemata screening project? Or
No, I'm not, and it pains to point that out. I'm not particularly politically involved or directly involved with that, but it's a large part of my work. I run an endoscopy unit in private, which is quite busy. And looking for bowel cancer is a lot of what we do all day long. It's just a major problem in New Zealand. I think the Waitemata pilot is fantastic. The results are brilliant and it's life-saving. And it's excellent that it's been announced in the budget that's going to get spread through further DHBs now. I think the amount of money promised is probably modest, but I imagine that will grow.
Yes.
There's got to be some pragmatism around this, but basically more adult New Zealanders need to get screened.
I get the impression that workforce is the biggest hindrance, and the government not wanting to make too many promises they can't keep. Do you see any light on the horizon as far as that's concerned?
Yeah, look, I'm sure that's true. I think the big barriers are going to be costs and workforce. Again, I'm not close to the project or the government. There's a lot of work going into that. The people running the Waitemata pilot are excellent. They're really very intellectually robust and they're looking at all these issues. I don't have an answer for them, but I think that it will be a challenge getting enough people to do enough endoscopy because, quite frankly, I think as awareness goes up and screening spreads, there will be a tsunami of colonoscopy on the way, which has got to get done. It's really important though because bowel cancer in New Zealand tends to present late, stage 3, stage 4, and a lot of those patients aren't curable. And they do much better, for example, in Australia and America where screening is much more active. The Waitemata studies showed that the patients who are screened who are turning up with cancers are stage 1 and 2, so they're curable.
Yeah.
So it's turned it on its head.
Yes. Now, the other talk you're giving today is on vomit, spew and poo.
Vomit and faeces, yeah.
Vomit and faeces, yeah, very topical. Yeah. So what are you talking to GPs about?
Yeah, well, the title, I think you've got to get them in the door.
Yeah, that's right. Yeah.
So much excellent stuff there. But it's from a GP's perspective. I had a good think, what would GPs find useful? It's specialists can stand up and start rabbiting on about their specialty and everyone falls asleep. But the challenge for the doctor, either at the bedside or in their rooms, is they have the patient in front of them reporting symptoms. Unlike in hospital, you have colleagues, you have scans, you have a laboratory to back you up and help you diagnosing. You've actually got to fly by the seat of your pants off in a general practice. So the whole thought of that was to try to interpret the symptoms and whether they're significant surgically. In other words, is there some feature of this vomiting or some feature of this bowel habit change that is pointing towards a surgical diagnosis, and that patient needs to get to a surgeon either acutely or subacutely.
So what are the take-home messages for GPs? What should they be looking for?
Well, it's not a simple thing, and I've got to add, GPs are really excellent at this, filtering, and they manage the vast majority of patients who have vomiting or diarrhea or whatever, because most of it's infective or has some other cause. So a lot of it stems to the associated symptoms and signs, so whether they have pain, whether they have abdominal signs that are significant. Sometimes the nature of, for example, the vomitus can be helpful, whether there's blood in it, whether it's high volume, perhaps suggesting a bowel obstruction, whether it's low volume and postprandial, suggesting perhaps biliary colic from gallstones. Similarly with bowel motions, as a broad rule, diarrhea is usually not surgically significant, but constipation may be. And certainly if there's blood, that needs investigating. And then within the category of blood, you can look at whether it's fresh or dark, whether it's streaky, whether the stool is grooved. So there's a lot of clues like that, and GPs are aware of this, but it's just reinforcing it and bringing it all together in one talk.
Great. Thank you very much for your time, John.
Thank you.